Good afternoon, sir.
Please proceed with the case.
Yes, sir.
My patient Ramesh, 29 years
Old, male, resident of Bihar, laborer by occupation, married. So he presented with chief complaints of palpitation since the last 4 years and breathlessness since the last 4 years.
Can you define palpitations?
Yes, sir. Palpitation is abnormal sensation.
of one's own heartbeat.
It can be due to change in the any chamber size of the heart, change in the rhythm, or change in the force of contraction.
So, can you tell me the causes of palpitations?
Yes, sir. So there can be cardiac causes of palpitation, which includes any arrhythmias like supraventricular tachycardias, atrial flutter, atrial fibrillation, ventricular arrhythmias, or there can be non-cardiac causes like hypoxia, asthma, COPD, or it could be due to severe anemia, thyrotoxicosis. It could be anxiety or hyperventilation syndrome. Palpitations can also be seen in the case of congenital heart diseases like ASD, BSD. It can also be seen if the patient has episodic hypertension, headache, and sweating. We can think of endocrine causes like pheochromocytoma.
Please proceed.
Patient was apparently alright 4 years back when he started having palpitations on exertion, which were insidious in onset, gradually progressive, irregular. He started having them on doing heavy manual work, that is NYHA class 1.
What is NYHA?
So NYHA is New York Heart Association classification for different cardiac symptoms. It can be used in a patient with known cardiac disease. So it can be used for dyspnea, palpitation, and angina. So there are 4 classes. NYHA class 1 is mild limitation in routine physical activity or symptoms on doing unaccustomed physical activity. Grade 2 NIHA is moderate limitation in doing routine physical activity or symptoms on doing accustomed physical activity. And NYHA grade 3 is marked limitation in doing regular physical activity or symptoms during less than accustomed physical activity. And grade 4 is symptomatic at rest. And increase to palpitation on walking a small distance, that is NYHA class 3. It increases on exertion and gets relieved on taking rest. It was associated with post-palpitation diuresis and shortness of breath.
What does it signify?
Sir, post-palpitation diuresis signifies that the palpitations have a supraventricular origin, that is the atria. So, when the arrhythmia is supraventricular origin, there is stretch of the atria, it causes release of atrial natriuretic peptide, and there is post-palpitation diuresis. So, it could be supraventricular arrhythmia. No history of syncope.
So, can you define syncope?
Syncope is a brief, sudden loss of consciousness due to decreased blood flow to the brain due to decreased cardiac output.
So, what are the causes?
Also developed breathlessness since the last 4 years, which was insidious in onset and gradually progressive. It started on doing heavy labor work, NYHA class 1, and increased to breathlessness on walking a short distance, NYHA class 3. Since the past 2 years, it is associated with dyspnea 2 to 3 hours after night sleep, causing awakening, and was relieved on walking and taking deep breath.
What is this?
So this is a classical history of paroxysmal nocturnal dyspnea, that is PND.
What is the mechanism of PND?
The mechanism of PND is that whenever the patient sleeps, there are 3 possible mechanisms. First of all, the fluid from the interstitial compartment shifts into the intravascular compartment, which increases the venous return. Secondly, as the patient shifts, the diaphragm moves upward, decreasing the vital capacity of the lung. And third is 2 to 3 hours after the sleep, the patient especially the night sleep, the patient enters the REM sleep, which causes increase in the sympathetic activity and causes the tachycardia. Tachycardia in turn decreases the diastolic filling time of the heart, causing the LV to fail. And when the patient gets up and he walks around, there is decreased venous return, and also when the patient takes deep breath, it resolves in 10 to 20 minutes and the patient can sleep again.
So, what does it signify?
Sir, PND is a very specific finding for the left heart disease. So this can narrow our diagnosis to the left sided of the heart.
So, what mimics PND?
So PND mimickers, first of all, we need to rule out asthma in this case.
Can you tell me how to differentiate between asthma and PND?
So the history is classically very similar, but once the patient gets up due to dyspnea, once the patient walks and takes deep breath, PND resolves on its own. But for the asthma to resolve, the patient always needs a bronchodilator. So this can help us. Other mimickers are obstructive sleep apnea, anxiety, GERD, post-nasal drip with severe cough. This can cause symptoms similar to paroxysmal nocturnal dyspnea. It is also associated with increase in the breathlessness 1 to 2 minutes after lying down and relieved on sleeping with pillows underneath or in propped up position.
What is this?
So this is a classical symptomatology of orthopnea. So
Causes?
causes of orthopnea, sir, basically we can see it in left heart failure. Secondly, we can also see it in COPD. We can also see physiologically we can see this in pregnancy or severe obesity. No history of chest pain. There is no history of loss of consciousness. There is no history of cough, hemoptysis, seasonal variation of breathlessness.
So, what are the causes of hemoptysis in our case?
Sir, causes of in our case, as India is a hub for tuberculosis. First of all, we need to rule out tuberculosis in our patient. There other causes could be pulmonary edema, recurrent pulmonary edema causing pink frothy sputum. Secondly, if the patient is on any drugs like anticoagulation, it can also cause hemoptysis. There can be pulmonary embolism. No history of Lewis discoloration of lips, tongues, and extremities to rule out congenital heart diseases, cyanotic. No history of abdominal distension, swelling of the legs. Past history. There is history of 2 episodes of sore throat at the age of 15.
Why did you ask this history?
There was no history of associated fleeting joint pains, chest pain, any rash, any involuntary movements. Sir, I asked this history to rule out the etiology of the disease, to find the history of acute rheumatic fever.
So, what is the criteria?
How do we diagnose this?
So the criteria which we use to diagnose this is modified Jones criteria.
What are the components of the Jones?
So the major criteria we have the 5 components, that is migratory polyarthritis. It is symmetric in nature. It involves the large joint. When one joint is affected, it resolves, the edema resolves, and it proceeds to involve the next joint. It is non-erosive. It is rarely erosive. If it causes mild deformity, it is called Jacquard's arthritis. The second is pancarditis. It can involve the pericardium, myocardium, or endocardium.
What is the most common valvular abnormality in acute rheumatic fever?
So the most common valvular abnormality in acute rheumatic fever is mitral regurgitation, sir. The third is subcutaneous nodules.
Can you show me the distribution of these nodules?
Sir, these nodules are seen on the extensor aspect of the patient's body. So there is a classical position. एक मिनट उठ के बैठना, ये फोल्ड करना, पैर ऐसा करना और ऐसा करना, हाथ ऐसा ऐसा, झुकना नीचे. So you can see on the extensor aspect of the legs, on the this extensor aspect of the
Forearm.
and forearm, and you can also see on the dorsal aspect. So these are the typical sites of subcutaneous nodules in acute rheumatic fever. So jao. The third is erythema marginatum. So it is a typical rash.
So, is it common in India?
No sir, we can't see this erythema marginatum in Indian patients. It is typically described in Western patients because of the dark skin tone in our patient. And third is the involuntary movement or typically of the tongue, that is Sydenham's chorea. So shall I proceed?
Yes.
What is the treatment of acute rheumatic fever?
Sir, treatment of acute rheumatic fever, it depends whether if the patient is not having carditis, we give high dose of NSAIDs, that is aspirin. We give it in the 80 to 100 milligram per kg dose. So for our patient who is 50 kg, we need to give 5 grams of aspirin in 4 divided doses per day for 2 weeks. And if the pain or ESR decreases, we can taper it over the next 2 weeks. And if the patient has carditis, then we need to give injection benzathine penicillin 1.2 million units IM after test dose. To prevent the rheumatic heart disease, we need to give secondary prophylaxis. So, if the patient has acute rheumatic fever without carditis, we need to give
Injection benzathine penicillin 1.2 million units.
IM after test dose every 3 to 4 weekly. We need to give for 5 years or till 21 years, whichever is longer. If the patient has carditis without any valvular lesion, we need to give this penicillin for 10 years or 21 years, whichever is longer.
So, what if the patient is allergic to benzathine penicillin?
So, we can give sir erythromycin. And if the patient has carditis with valvular lesion, we can give for 21 years or till 40 years, whichever is longer. But most of the clinicians prefer to give penicillin lifelong if the patient has valvular lesion.
Subscribe the channel for more such clinical videos.
There is also a history of left upper limb and lower limb weakness 2 years back, which improved over the next 3
What do you think is the etiology of the CVA?
The possible etiology looks to me as cardioembolic, sir, because the weakness was sudden in onset and maximum at the onset, and it was associated with palpitation. The patient did not show to any doctor and was at home for the same. The patient had shown to an allopathic doctor 10 months ago for his palpitation and breathlessness, where he was told that he has some heart problem and he was started on an injection 4 weekly IM.
What is this?
So, this injection is most probably injection benzathine penicillin started for the secondary prophylaxis to prevent rheumatic heart disease. The patient left the injection 3 months back, sir. Patient was also given a tablet which was to be taken in the evening with 2 hours fasting before and after taking the tablet. And he was also advised a blood test which was to be monitored every 2 weekly to titrate the dose of the tablet.
What is the tablet?
So this tablet could be tablet warfarin, which is taken with fasting 2 hours before and after the dose, and also the test which was told to be monitored looks to be INR.
Can you tell me about some other drug histories?
Sir, other drugs which can be said are, if the patient is giving history that he is asked to take a drug for 5 days per week and he is asked to omit the drug on Saturdays and Sunday, the drug is most likely to be digoxin. And if the patient complains that after taking the drug, the patient has increased urination, it is most likely diuretic, likely tablet furosemide. There is no history of fever, dental or genital procedure or IV drug abuse.
Why did you ask this?
Sir, I asked this to rule out infective endocarditis in my patient. There was no history of diabetes, hypertension, tuberculosis contact, unprotected sex and genital ulcer.
Why did you ask this?
Sir, I asked about unprotected sex and genital ulcer to rule out syphilis.
Why?
So the cardiovascular abnormality which syphilis can cause is aortic root dilatation and syphilitic aortitis, which can lead to aortic regurgitation. Personal history: the patient is chronic alcoholic, drinks 1/4 of liquor per day since the last 8 years, last drink 2 months back.
What is the significance of alcohol in our case?
Sir, alcohol can lead to various cardiovascular abnormalities, such as it can lead to dilated cardiomyopathy causing dilatation of all the 4 chambers of the heart. It can also lead to atrial fibrillation. So this is called holiday heart syndrome.
What is this called?
Patient has mixed diet, normal bowel and bladder habits. Family history is not significant. There is no history of diabetes, hypertension, ischemic heart disease or sudden cardiac death in the family.
Can you summarize the history?
Yes, sir. So I'll summarize the case. 29 years old male, chronic alcoholic with past history of cerebrovascular accident, came with chief complaints of progressive exertional dyspnea and palpitation of 4 years duration. So this looks to me of cardiovascular system
What
and
system does
mostly
it
involving the
look to?
left side of the heart, because the patient has palpitation and breathlessness. He also has PND, which is more specific to the cardiovascular system, and orthopnea.
Proceed to examination.
Now we'll proceed to the examination. The patient is well built, weight of 52 kg.
Is there any significance of doing daily weight in our patient?
So the significance of weight in our case is we need to monitor daily weight in our patient so as to find whether the patient is responding to the diuretics. If the edema is resolving, the weight can increase or decrease daily. The height of the patient is 160 centimeter. The BMI is 23 and arm span is 154 centimeter.
Why did you ask about arm span?
Sir, actually I wanted to compare the arm span with the height, because if the arm span is larger than the height, I might think about Marfan syndrome.
What are the cardiac abnormalities associated with Marfan syndrome?
Yes, sir. Marfan syndrome is typically associated with aortic root dilatation causing aortic regurgitation. It can also be associated with mitral valve prolapse. So, general examination: the patient has no pallor, icterus, cyanosis, clubbing, or pleural edema. Now, I'll proceed to the vitals. Pulse is 73 beats per minute. Irregular, normal in volume, character. All peripheral pulses are felt. There is no radioradial or radiofemoral delay. The apex pulse deficit is 12. Normal vessel condition.
Can you define pulse?
So pulse is the pressure wave which is transmitted across the arteries due to left ventricular contraction.
What is the normal character of pulse?
So the normal character of pulse is catacrotic in nature.
There is a percussion wave, tidal wave, and the dicrotic notch in the diastole.
It is irregular.
What are the causes of irregularly irregular and regularly irregular pulse?
So regularly irregular pulse is seen in supraventricular tachycardia with fixed AV block, and irregularly irregular is seen in supraventricular tachycardia with variable AV block like atrial fibrillation, atrial flutter with variable AV block. The pulse is normal in volume.
Why did we say pulse is normal volume?
Sir, ideally one should see for the pulse pressure, which one can know after measuring the systolic and diastolic BP. If the pulse pressure is within normal range, one can say that the pulse is normal in volume.
What is pulse pressure?
So pulse pressure is systolic BP minus diastolic BP. The pulse is normal in character.
What are the different characters of pulse you know?
The normal character of the pulse is catacrotic, sir, and the other pulses of other characters one can say of is pulsus parvus et tardus. That is a slow rising and late peaking pulse. We typically get this pulse in aortic stenosis. We can also see pulsus bisferians. It is a pulse with 2 peak in the systoles. It is specifically seen in the HOCM. Pulsus alternans, which has pulse of different force of contraction. So it can be seen in left ventricular failure. Pulsus paradoxus.
What is pulsus paradoxus? Is it primarily associated with pulse?
No, sir. Actually, pulsus paradoxus is a misnomer. It is associated with blood pressure. Normally, on inspiration, the blood pressure falls. If the fall is greater than 10 mm of Hg, then we say this is pulsus paradoxus. It is typically seen in constrictive pericarditis, restrictive cardiomyopathy. There is no radioradial or radiofemoral delay.
Where do you get exaggerated radiofemoral delay?
Sir, exaggerated radiofemoral delay can be seen in coarctation of aorta. The patient has apex pulse deficit of 12.
How do you see for the apex pulse deficit?
Ideally, sir, we need two persons to demonstrate or see the apex pulse deficit. One will look at the pulse of the patient, and one person will look at the pulse of the patient, and the other person will auscultate at the apex and measure the heartbeats in 1 minute. So once we have done this for 1 minute, we'll subtract the apex beat which we have heard with the stethoscope
From the pulse rate.
So the deficit which we get is the apex pulse deficit.
Its significance.
If this apex pulse deficit is greater than 10, we should suspect of atrial fibrillation. And if it is less than 10, we should think of ventricular premature contractions. The condition of the vessel is normal. Blood pressure. The blood pressure in the right upper limb was 110 by 68 millimeters of mercury. In the right lower limb was 120 by 70 millimeters of mercury. In the left upper limb was 112 by 68 millimeters of mercury. In the left lower limb was 120 by 70 millimeters of mercury.
Why is it?
Is lower limb BP actually higher than upper limb?
Actually, the blood pressure in all the four limbs is equal, but this increased blood pressure in lower limb is due to the artifact of the cuff length.
Can you tell what is Hill sign?
So Hill sign is exaggerated BP in the lower limb than the upper limb. If the value is greater than 20, it is a Hill sign. It is seen in moderate aortic regurgitation. The pressure, jugular venous pressure, is 6 cm above the angle of Lewis.
What is the normal JVP?
The normal JVP is 3 to 5 cm above the sternal angle. The respiratory rate is 18.
Do you know what is hepatojugular reflux?
Sir, hepatojugular reflux is a reflux where on pressing the right hypochondriac region, there is an increase in the jugular venous pressure. Ideally, after 5 to 10 seconds, the pressure should drop. But if there is sustained rise, it is hepatojugular reflux is abnormal and it indicates right heart failure.
Can you demonstrate?
Yes, sir, I can demonstrate. To demonstrate this, we will make our patient in 45-degree supine position. Now I will press in the right hypochondriac region and we need to observe the internal jugular pulsations. So now I have pressed, and as you can see, there is significant rise, and this rise is sustained. There is no fall.
So this is abnormal hepatojugular reflux.
Shift to CVS exam.
Yes, sir. मैं आपका अभी कुछ तपास करूंगा. आप शर्ट निकाल सकते हो क्या? On inspection, the trachea looks central. So for this, we need to look at the two heads, external head of the sternocleidomastoid. If there is prominence of any one head, the trachea is deviated to that side. The trachea looks in the midline. There is no आप सो सकते हो क्या? अभी सो जाओ. आगे आ जाओ थोड़ा सा. The chest wall looks symmetric. There is no obvious precordial bulge. Now there is no dilated scar, sinuses or veins seen. There is no pulsation seen. Now I'll see the apex beat. So we'll see apex beat.
Will you demonstrate apex beat?
Sir, apex beat. I'll see it from the right side of the patient tangentially. So in this position, I'll see. So the apex beat is in the left fifth intercostal space, 1 to 2 centimeters lateral to the midclavicular line. Where is the normal apex beat? The normal apex beat lies 2 centimeters medial to the midclavicular line in the left fifth intercostal space. So our apex beat is shifted outwards. Apex beat seems to be localized. There are visible left parasternal pulsations. Yes, I will demonstrate it. As you can see, this left parasternal pulsations. What is the significance of this? So this signifies right ventricular hypertrophy or left atrial enlargement. This could be due to pulmonary hypertension. There are no suprasternal, epigastric or supraclavicular pulsations. So I will see the supraclavicular area. There are no obvious pulsation. The epigastric area. Shall I proceed to palpation, sir?
Yes.
So I warm my hands first, and I start with seeing the apical impulse first. So I will place my hand on the precordium, and I feel the point where there is maximum feel of the apex beat. Then I will turn toward the ulnar border, and I place one finger, and the point where there is maximum force, I'll place the tip of my finger. So once we see this, first I'll see the angle of Lewis. As you can see, the rib attached to it is the second rib. So below it is the second intercostal space, third intercostal space, fourth and fifth. So I'll see in the fifth intercostal space. So here is our apex beat. So this is the midclavicular line roughly. So our apex beat is 1 to 2 centimeters lateral to the midclavicular line. So the apex is out apex.
What are the causes of out apex?
So the causes of out apex are, if the patient is having LV hypertrophy, pressure hypertrophy, it causes the out apex. It is seen in aortic stenosis, systemic hypertension.
Causes of down and out apex.
If there is volume overload of the left ventricle, the apex is down and out. It is seen in hyperkinetic states like
Mitral regurgitation and aortic regurgitation.
apical beat is located in the 50 intercostal spaces, 2 cm lateral to the midclavicular line. It is tapping in nature and it is localized to one intercostal space.
What is tapping apex?
So tapping apex is that the apex is localized to one intercostal space and it gently just touches the finger.
Where do you see this?
It is typically seen in mitral stenosis.
What is heaving apex?
So heaving apex is the apex which is sustained, which remains in contact with the finger for greater than 2/3 of the systole. It is seen in aortic stenosis.
What is hyperdynamic apex?
Hyperdynamic apex is the apex which is diffuse and is localized in more than one intercostal space. It is seen in mitral regurgitation or aortic regurgitation. There is palpable thrill in the apex area which is asynchronous with the carotid.
Demonstrate.
So I'll demonstrate. I'll show. There is a tip. So this is my hand. So with the tip of the fingers, you will feel for pulsations. With the head of the metacarpals, you will feel for the thrill, and with the base of the hand or the ulnar border, you will feel for the heave. So for the thrill, I use the head of the metacarpals. So I place this over the apex beat. I'll ask the patient to turn toward the left side. And I simultaneously I feel the carotid. So if the thrill is synchronous with the carotid, it is a systolic thrill, and if it is asynchronous with the carotid, it is diastolic thrill. So our patient has diastolic thrill asynchronous with the carotid. सीधा होना.
What inference can you draw from the thrill?
Sir, this signifies that if the patient has a murmur, it is either minimum grade 4 murmur, because thrill is seen in grade 4 murmur.
What are the different grades of murmur?
Sir, murmur has typically 6 grades. Grade 1 is very soft murmur, which is heard in a quiet room. Grade 2 is soft murmur. Grade 3 is moderate intensity. Grade 4 is loud murmur with a thrill, palpable thrill. Grade 5 is very loud murmur, which is heard with the rim of the stethoscope. And grade 6 is a murmur which can be heard with the stethoscope a few centimeters away from the precordium. There is a left parasternal heave which just lifts the hand.
What grade?
Sir, this is grade 3 of heave.
Because heave which is visible and lifts the hand is grade 3. Demonstrate.
Yes, sir, I can demonstrate. So, this is my hand. So, we follow the shortcut PTH, that is parathyroid hormone. Pulse with the tip of the fingers, thrill with the head of the metacarpals, and heave with the base of the hand or ulnar border. So, we'll do with the ulnar border. I place the ulnar border of my hand in the left parasternal area. As you can see, it lifts my hand. So this is the left parasternal heave.
Any other methods you know?
We can also do it with a pen. So I place a pen in the left parasternal area. As you can see, the pen is lifted upwards. This is due to the left parasternal heave. Shall I proceed, sir?
Yes.
I can also feel for the epigastric pulsations with the tip of the thumb.
Can you show me?
Sir, I'll demonstrate. Sir, so I'll place a thumb below the xiphisternum in the epigastrium. So I can feel the pulsations at the tip of my thumb.
Any significance of this?
Yes, sir. So if I feel the pulsations on the tip of my thumb, it indicates that something from above is hitting the tip of my thumb, that is right ventricular hypertrophy. And if I feel it with the pulp of my thumb, it indicates something from below is hitting, that is the aorta. So it indicates aortic pulsations. Percussion, there is mild dullness in the pulmonary area.
Demonstrate.
see the angle of Lewis, the rib adjacent is second rib, I'll go below it, left parasternal, I'll percuss. So there is mild dullness.
What does it indicate?
So this indicates pulmonary artery dilatation or pulmonary hypertension. It could be, the dullness could be either due to right ventricular enlargement or left atrial enlargement.
Did you percuss the heart border?
Sir, I did not percuss the heart borders because as this patient has irregular pulse, the patient is in atrial fibrillation and there is a risk of embolisms.
Good.
So now shall I proceed with the auscultation?
Where do you auscultate?
Sir, we auscultate typically in 4 areas: the mitral area, tricuspid area, aortic area, and the pulmonary area. So the mitral area normally is in the fifth one at the apex beat, that is fifth intercostal space, 2 centimeters, 2.5 centimeters medial to the midclavicular line. So in our patient, we should auscultate laterally at the apex beat. So here is the mitral area at fifth intercostal space. At the fourth intercostal space, left parasternally we have the tricuspid area, and in the second intercostal space, on the left side parasternally we have the pulmonary area, and similar to it on the right side, second intercostal space, we have the aortic area.
Can you guys comment where is the new aortic area?
So now I'll proceed with the auscultation. I'll auscultate at the
Subscribe the channel for more such clinical videos.
mitral area first. So there is loud S1 with varying intensity of S1. So I can hear an opening snap. S2 is also heard. There is no obvious S3 or S4. So I can also hear a mid-diastolic rumbling murmur with the bell of my stethoscope with no pre-systolic accentuation. Sir, the murmur is, sir, to hear it better, I would like to make the patient in the left lateral position. Udhar ho jao. Now I'll ask the patient to take a deep expiration and hold the breath. लंबा सांस लो और रोको, लंबा सांस छोड़ो और रोको, छोड़ो और रोको, छोड़ो और रोको. Sir, I could hear loud and variable S1. Opening snap was present. There is soft mid-diastolic murmur with no pre-systolic accentuation. Best heard with the bell of the stethoscope in the left lateral position and breath held at the end of the expiration.
Why so?
Sir, this is because there is a general rule that the left-sided murmur increase on expiration and the right-sided murmur increase on deep inspiration. And once we make the patient in the left lateral position, the apex beat comes closer to the ventricle comes closer to the heart, and the flow across the mitral wall increases in that position. So we can appreciate the murmur better way.
Why is S1 loud in mitral stenosis?
Sir, at the end of the diastole, the mitral wall leaflets are far apart and they have to cross a larger distance to get close. And the left ventricle has to generate more pressure against the dilated atria. So this causes a loud S1.
When does it become soft?
Sir, the S1 becomes soft if there is concurrent mitral regurgitation, or the valve is calcified, or there is atrial fibrillation.
Where do you get mid-diastolic murmur?
So the other causes of MDM are Caricombs murmur, which is seen in the acute rheumatic fever (MR). Then there is Austin-Flint murmur, which is heard at the apex, which is seen in aortic regurgitation due to when the regurgitant jet hits the anterior mitral wall leaflet. It can be also associated with flow murmur, which is seen in ASD, VSD. It is also seen in tricuspid stenosis. Tricuspid area, so S1 is variable and S2 is heard. Pulmonary area, S1 is variable and P2 is loud. Aortic area, S1 is variable, S2 is heard. The respiratory system is clear. The per abdominal examination is also within normal limits.
So what is the final diagnosis?
Sir, this is a 29 years old male, most likely a case of acquired valvular heart disease, that is moderate to severe mitral stenosis.
Why do you say it is severe?
So because the patient is having palpitation and dyspnea, and he is also, by examination we got to know that the patient has left parasternal heave indicating pulmonary hypertension and right ventricular hypertrophy, which falls in the severe grade. The etiology being mostly rheumatic heart disease with atrial fibrillation, with pulmonary hypertension, with signs of left ventricular failure, without any evidence of infective endocarditis and acute rheumatic fever.
How will you proceed in this patient?
Sir, in this patient, I will proceed with CBC ESR to look for any ongoing infection or inflammation. I will do the ECG for my patient.
What do you expect in the ECG?
In the ECG, I can see left atrial enlargement where there is biphasic P waves in V1. I can also see right ventricular hypertrophy. I will proceed with the echocardiography after that.
How do we grade MS on echo?
So the MS can be graded as progressive MS, where the normal mitral wall area is 4 to 6 centimeters square. So if the area is greater than 1.5 centimeters square, we say it is a progressive MS. and the other is the severe MS, where the area is less than 1.5. It can be symptomatic or asymptomatic. So these are the grades of MS.
How will you manage AFib in this case?
Sir, as this patient has palpitation since the last 4 years, this is considered to be permanent AFib. So I will proceed with the rate control, that is with the heavy nodal blocker agents, that is beta blockers, non-hydropyridine calcium channel blockers like diltiazem, and if the patient is in active heart failure, I'll give digoxin. And whereas anticoagulation, sir, the possibility if the patient has valvular atrial fibrillation that is moderate to severe aortic mitral stenosis, we need to give the patient vitamin K antagonist, that is warfarin, and we need to overlap this with heparin, and we need to monitor INR of the patient. If it is a non-valvular AFib, we will see the CHAD-H2 VAC score.
Can you elaborate what this score is?
So it is a score which contains congestive heart failure, hypertension, age. If the age is greater than 75, the score is 2. Diabetes, sex. For female sex, the score is 1. Male sex, the score is 0. Prior history of stroke or TI, this has score of 2. History of peripheral vascular disease. So this was the CHAD-VAC score. Each score has a point of 1, and age greater than 75 and stroke has 2 points each. So if the score is greater than 2, we give anticoagulation. We can proceed with the direct oral acting anticoagulant, that is DOACs. We can give apixaban, rivaroxaban, dabigatran.
Do we need to give heparin overlap with DOACs?
Yes, sir. Overlap is needed only with dabigatran. Apixaban, rivaroxaban can be given without overlap.
What will be your treatment strategy for this patient?
So now, as the patient is severe MS and symptomatic, we will proceed for the surgery. So we have 3 possible options: balloon mitral valvuloplasty, open mitral commissurotomy, or mitral valve replacement.
Have you heard about Wilkins score?
The Wilkins score is a score which decides whether the patient can go for BMV. It includes the pliability, thickening, calcification of the mitral valve. So if the score is less than 8, the patient can go for a balloon mitral valvotomy.
Can you tell me the contraindications of BMV?
The contraindications of BMV are, sir, plaque clot. If the patient is having mitral regurgitation, grade 2 or more. If the patient has any of these, the patient should go for mitral valve replacement.
Subscribe to the channel and do let
Thank
us
you,
know how was the case in the comment section.
Sure.